Good afternoon, everybody. Thank you for coming. I am so delighted to be here today. It is my first Gibbs Oration, and I am just so happy to see so many smiling faces in this room, and just couldn't be happier to have one of my closest friends and dear colleagues here with us. Today is the 35th annual Gibbs Oration, and I'm thrilled to have this as an event for National Public Health Week. Today is day 4. I'm so proud of all the events that have happened here in the school over the past 4 days. For those of you who haven't had a chance to see, please see the banners with all of the tags for what makes you excited about public health. We've had the hygiene drive, the food drive. We had the president here earlier in the week. Yesterday was our practice partners. We have exciting events tomorrow. It's just been a wonderful, wonderful week, and I'm just so delighted that we're going to be able to celebrate even more today. So I'd like to welcome our colleagues across the various schools at GW. A shout out to our admissions team who is at James Madison University today hosting a watch party. So welcome, Duke, so thank you. And I'm truly delighted to see all of you here in person and those of you who are joining us online. We want this to be a candid conversation, and so we're going to ask for all of you to not record this so that this can be a very open dialogue and that Dr. Walensky can have the opportunity to answer questions honestly and fairly. I want to give my sincere thanks to the Public Health Students Association for their incredible efforts to put together all of the things we've had this week as part of National Public Health Week. And I really want to give you a kudos to David for his engaging and really putting this all together. I also want to thank our development team and alumni relations and all the many colleagues across the school who have made today possible. Today is especially meaningful to me on a personal level because I've had the privilege of knowing Rochelle for 30 years. We met when we were just toddlers, actually. But having the chance to welcome her here to the stage at GW is an extraordinary honor for me. This is a woman who has had professional experiences that we cannot imagine, who has led through amazing challenges in public health and has really served our country in a way that we are just truly indebted to. I've had a front row seat to Rochelle's integrity, her clarity of purpose, and her unwavering commitment to doing what is right, even in the most challenging of moments. What you have seen publicly is what I have lived privately with her. She's thoughtful, principled, and deeply grounded in the mission of improving public health and improving people's lives. She's also incredibly kind, generous, and a very humble leader. I can't think of a more important voice in public health at this moment, and I am just so delighted that she has chosen to be with us here today. We're living in a time when public health has come under attack, not only in terms of scientific integrity, but it requires courage, communication, and trust. Rochelle embodies all 3 of these things. I'm going to leave the formal introduction to the 2 of my most trusted and beloved leaders at the George Washington School of Public Health, Len Friedman and Bob Bonar, currently who run our MPH program, which is ranked 8th in the nation. Okay. And for those of you who don't know, the Milken Institute School of Public Health is number 11 this week, so 3 cheers for Milken. So Bob and Len have been 2 wonderful colleagues who've been deeply supportive partners to me in my first 6 months. In fact, the first class that I attended was Bob's class, and actually the last class that I went to just last week was Len's class, which is kind of amazing. So their wisdom and steadiness and commitment to our students and our fields have helped shape our program and our school in so many ways. I'm grateful to work alongside them. With that, I'd like to invite the both of them to the podium for our opening reflections. Thank you.
Wow, this is something. Thank you, Kelly. I appreciate this very much. It is truly a privilege to be part of the 35th annual Gibbs Oration. For more than 3 decades, this event has brought together leaders across healthcare and public health for thoughtful and often candid conversations about where our field is and, more important, where it is headed. The Gibbs Oration was founded to honor Professor Frederick Gibbs. For those who have not heard of him, Professor Gibbs was the founding chair of the then Department of Health Services Management and Leadership when the George Washington University Board of Trustees decided to establish a brand new degree in hospital administration. That degree was founded in 1958. The first class was admitted in 1959. His vision helped create the foundation for generations of health sector leaders and pioneering innovation in our field. Thanks to the continued generosity of alumni, faculty, and friends, these lectures have endured as a way to carry forward his legacy, one that is grounded in leadership, innovation, and, leadership, innovation, and a deep commitment to improving health systems. Professor Gibbs' mission today feels more relevant than ever. As Kelly mentioned, we are in a moment where public health and healthcare are being tested in profound ways. The challenges we face are not just technical. They are about trust, communication, leadership, and how we navigate uncertainty in real time. It is why it matters so much who we learn from. Over the years, this stage has featured individuals who have shaped policy, advanced practice, and strengthened institutions across our nation. Today, we continue that tradition with a leader who has done all of these under often extraordinary circumstances. For our students, particularly who are in the audience today, this is a rare opportunity to hear directly from someone who has led at the highest levels and to reflect on what type of leadership is truly required in these times. Before I hand off to my good friend, Dr. Bonar, I'd like to add one final point. That is, this field is built not only on ideas, but upon relationships. One of the things I tell my students, and you'll excuse me if I'm repeating myself, but relationships are primary, all else is derivative. Keep that in mind. The ability to lead effectively is grounded in the strength of the communities and the colleagues who surround us. I'd like to turn the microphone over to my dear friend and colleague, Dr. Bob Bonar.
Thank you, Lynn and Kelly. And good afternoon, everyone, and welcome. It is now my pleasure to introduce our moderator and our distinguished guest. We are fortunate enough to have with us today our Public Health Student Association President, David Goldstein. Welcome. David is a health policy leader and clinician with more than a decade of experience in advancing public health innovation and health system transformation. He currently serves as the Director of Policy and Strategic Initiatives at the Healthcare Transformation Task Force, where he works to accelerate the shift toward high-quality, affordable, and person-centered care. Prior to this role, David served at the U.S. Department of Health and Human Services, where he advised on national public health strategy across medicine, research, and public health. He also held leadership roles at the Centers for Medicare and Medicaid Services and the Center for Medicare and Medicaid Innovation, where he helped design and implement value-based care models that are focused on population health, behavioral health, and complex care. David began his career as a clinician and is trained as an occupational therapist. He has remained deeply committed to connecting policy with real-world impact. He's also part of our GW community and is currently pursuing his doctorate in public health. So we are grateful to have him here today to guide today's conversation. And it is also my distinct honor and privilege to introduce Dr. Rochelle Walensky. Dr. Walensky is an infectious disease physician, researcher, and public health leader whose career has been defined by a commitment to evidence-based decision-making and improving health outcomes at scale. She served as the 19th director of the Centers for Disease Control and Prevention, leading the nation through the height of the COVID-19 pandemic and navigating one of the most complex public health periods in modern history. Prior to that role, she was the chief of infectious disease at Massachusetts General Hospital and a professor of medicine at Harvard Medical School. Her research, particularly in HIV, has shaped policy and expanded access to care both in the United States as well as globally. She is a member of the National Academy of Medicine and continues to contribute to the field through her work with leading institutions and organizations. As Kelly noted earlier, she's also a trusted colleague and friend, and we're lucky and very fortunate to have her with us today. So please join me in welcoming David Goldstein and Dr. Rochelle Walensky.
All right. Can folks hear? Yes. Welcome. Thank you so much for those intros. Thank you so much, Dean Gibbs, for supporting this really, really great opportunity. Happy National Public Health Week to everyone. And thank you, Dr. Walensky, for being here. It is truly an honor. I know that folks are really excited for this opportunity to hear from you. And so without further ado, I'd like to go ahead and get started. Just a note for folks, we do have folks joining online. We have a full audience here. There will be an opportunity for Q&A after, so please think of those questions as we go. And so I will help to moderate that after our chat is over. So I think starting, I'd like to ground everyone in your career and path, kind of going back a little bit, your personal journey. So what drew you to infectious disease and public health? And did you always imagine yourself at the helm of a place like CDC?
First of all, it's an honor to be here. Kelly kind of knows this, or Dean Gibbs kind of knows this, but when she asks me for something, the answer is yes, and I think generally it's true the other way around. That's what good friends and relationships mean, right? What an honor to be here, especially during Public Health Week and with you. I was with Kelly as an intern in inner city Baltimore in 1995. And that was the year, for those of you who were there can remember, of the cocktail for HIV. That was the year the third drug came about. It was instrumental in my career and in many of our careers during that time. I think we were a house staff class of about 30, and I think 10 of us went into HIV. And what I saw during that time, or infectious disease, what I saw during that time, in addition to the incredible friends and colleagues that I made, was this incredible intersection of really new novel science and the people who couldn't afford to benefit from it. And that intersection was pretty stark for me. At the time, those drugs were $15,000 a year, and our patients were not the kind of patients who could afford those. So there was new and novel science happening all the time. There was the potential for so much life-saving, and yet they were not in a position to be able to afford it. So that is why I went into HIV. That is why I became an infectious disease doc. That is why I did mathematical computational modeling to understand the cost effectiveness of these drugs. Just FYI, these drugs are now about $50,000 a year. So that is what sort of was my North Star. I had no aspiration to run an agency like, I mean, we aspire for things in our career. I aspired to be a professor. I aspired to one day be a division chief. So I did aspire. CDC was nowhere on my radar. It didn't even dare aspire there.
Absolutely, yes.
I also didn't apply for the job, just to be clear.
Duly noted, right. I heard some chuckling. You know, it's so interesting to hear your story and a lot of other folks too. It's sort of like we look for where the opportunities are to really have the impact. And I heard that from you. I think it's really important to note that. And I'm really glad that you did become the head of the CDC, right? So, so I want to transition a little bit. So you became you had your background, your journey, the head of the CDC. I think we're here because we're talking about leadership in public health, right? That's what's grounding all of us here. That's why we come to study in this space. There's a lot of gaps, a lot of need. And so help folks to understand a little bit, you were making these, you had to make these choices, right, where there were life and death implications as part of your job, right? And as a leader, sometimes we have to weigh things, right? So help folks to understand, how did you carry that responsibility both personally as well as in your day-to-day work, right? It must have been
heavy. Maybe I'll just, if I can back up a little bit to give you some of the runway that got me to some of those heavy decisions. And that was, I received a phone call in the middle of COVID. It was November, just after Biden had won the election of 2020, that I was not expecting, asking if I would, it was actually a voicemail from Ron Klain, a 202 area code. I Googled the name and confirmed that it was in fact Ron Klain. I called my husband before I called him back, and my husband said, whatever he asks, don't say no. Which he knows his wife, because that probably would have been what I said. And so that opened the conversation to sort of say, there's a position and we'd like you to consider the position at CDC. Now, my first imposter syndrome place was, this is an impossible job. There's no way to succeed at this job. How could I possibly do this impossible job? And the other piece is, how could you possibly not do this impossible job when somebody is calling you for help? And I likened it to sort of carrying the code beeper as a resident. You don't look at that code beeper when it goes off and say, I wonder if I can do this code. I wonder if I can run this code. I wonder if I can save this life. You look at that code beeper and say, I'm called to go somewhere to try and help and do the best that I can. And so that's kind of what I felt like the nation, my code beeper for the nation was going off. And so I struggled with how could I do this job and how could I not do this job for a little while, and you don't really know where you are in the vetting process. But it was one of these moments where I would say, I've been called to serve, and that's what I'm going to do. And so when I was in that position then, it gives me a little bit of permission to say, if I can't do it the way I can, with the most integrity that's possible, if I can't look in the mirror every single day and know that I've done the absolute best that I can, knowing that these are going to be some really hard decisions, then I'm done. And that actually gives you a little bit of a peace of mind to be able to say, I'm going to do this the way I feel is best, or because I never asked for this job, I'm going to do the way I feel it's best. So that was actually a pretty healthy state of mind for as difficult as the position was. What I learned in some of the things that I wish I had reflected on, I've read a whole bunch of leadership books that I wish I had read before I started, there were only hard decisions that came to me. If you are in a leadership position, then anything that's easy is made by somebody else, right? So by definition, anything that came to me was hard. And that meant, by definition, anything that came to me meant somebody was going to be hurt by the decision that I made, period. So I said to my chief of staff early on, I was like, why is everything so hard? And it was because every decision hurt somebody, or it didn't go their way. And so among the things that I learned as I was making those really hard decisions in imperfect times was to at least see the people who I was, to reflect back and say, I saw your position, it didn't go your way. And anything else I can do, because this one I can't do for you, but what else? How else can I be helpful? How else can I be there for you? How else can we as an agency be there for you? So that was among the things that I really tried to do. The other thing I really tried to do in these really hard, heavy decisions was to start to say, and these are learned skills that I was burned a few times, then you learn, is what can't I see? I had an incredible 25-year career at Mass General where everybody who's in those walls is generally sick. And so you get a bias by the fact that everybody is generally sick in how you take care of them in the public health work that I did as a researcher. When you go into government, it turns out that like health touches everything. It touches everything. And I have so many stories about, you know, where and how I would make a health decision over here and something would knock down at the Bureau of Prisons or in the Coast Guard, and you just didn't see it coming. So a lot of it was like, what can't I see? What are all the downstream effects? I'm a decision scientist, so like we think about all of the downstream effects of what we're doing. And I really got better at those kinds of things.
Absolutely, thank you. I hear a few components here I want to emphasize. It's sort of having trust in yourself as a leader, right? Is understanding yourself, knowing that you can do it, right? And then being thoughtful, seeing the system, right? I also think that as public health professionals, that's such a core component of what we study, right? And
yeah, well, and I will also say, like, it wasn't like, oh, I stood up there and I said, like, I can do this. There were plenty of times I might have called Kelly and said, like, oh my God, what have I gotten myself into? But it's, you know, there is also a component of like having your people. And I can tell you that, like, and part of the message that I tell other people, especially in these kinds of groups, is how much it matters to have your people. You could have a really terrible headline on the top of the New York Times, and if Kelly Gibbs texts you and says, you okay today? I'm good. And if you can have a really terrible hearing in front of Senate help, and if a third grader bakes you cookies that day, I'm good. And like, those are the kinds of things that happen to me. Like, a third grader would leave me a cake that said I got my vaccine today. I'm like, okay, I'm so good, I can do this. So it really did remind me of the tiny little things that matter that we can do for one another, that, you know, really, like, you can have a terrible headline and all you need is a dozen cookies. Like, it's kind of amazing. So there was a component of like believing in myself, making sure that my you know, I was always able to look in the mirror, that my star, you know, I was looking at the North Star, and then that the people around me who I trusted believed in me. That mattered more than I can ever say.
Absolutely, thank you for that. So we've talked again, you know, you were in this role with COVID. You know, you were developing, understanding, trying to find the right directions. Leadership is about trust and communications. Public health wasn't, and it isn't, just about science, right? How it's communicated is so important, right? And we saw that in COVID, we see it now, it's really important. And so can you talk a little bit about what were some of those challenges that you recall that you have experienced about how things have been communicated, and then what you would say to future leaders in terms of how we can maybe improve or learn from things that maybe weren't communicated exactly perfectly?
Oh man, how long do we have? First, I will say we are underskilled. We in public health are underskilled in communication. I had done a reasonable amount of communication in, like, speaking at a national conference, or I had actually been a CNN medical analyst for the entire first year of COVID. I had been on TV 3 times a week on CNN, and I still really would have benefited from more communications. My communications director at CDC, the position had been empty for 4 years when I got there. And I started on January 20th, and on January 23rd, we had our first of 3 times a week White House press conferences. I did 100 in the first year without a communications director. We could use more support in communications. And there is a science in communications that I don't know as well. I'm not a studied scientist in communications, but what happens when Tucker Carlson tweets disinformation about CDC and tags me? What's the proper approach to that? Do you retweet Tucker Carlson and propagate disinformation? Do you tweet the correction from the CDC director website, which probably has zero overlap with Tucker Carlson? But there is actually a science behind how you do that. I will also say that I have spent a lot of time over the last 2.5 years reflecting. One of the things that I did do, I don't recommend this, but I did do this, is I printed my calendar before I left CDC, and it had every media hit that I did. And I watched them all. Yeah. If I took a couple of months and I just said I needed to, because I wanted to learn. So many people had said I was really bad at communications. So I wanted to watch them and say, where were the good ones? Where were the bad ones? What could I have done better? It turns out, if you took an action on something for the entire week prior, I'd be on, all these news hits that would say, how come you haven't done this yet? How come you haven't done this yet? How come you haven't done this yet? And then I'd do it. And the next week was like, so fast? How come you did this so fast? Nobody was ready for this. So when you watch that in retrospect, you're like, there was no winning there. And so that's actually very helpful. So I tell you that in the next context, which is, when I think about the things that I wish I had done better and really reflect in those in the sort of quiet moments, there were so many decisions that we made, imperfect people with imperfect data in imperfect times. I stand behind all the decisions that we made, given the data that we had at the time. However, where I could have done better was in the comms around it. And so that's really where I would say, the rollout of whatever decision you make matters a lot, and that's really where I would have benefited from doing things differently in certain situations. I will also say 2 more things. One is the role of the media is to sell clicks and airtime. And they'd like to get it right. Don't get me wrong, I do believe they want to get it right. But their main job is to sell clicks and airtime. And it is oftentimes that the story is right and the headline is not. And oftentimes the journalists don't actually write the headline, the editorial board writes the headline to get clicks, right? So sometimes I would read the headline and be like, oh my God, and then you read the story and it was actually okay. So there is that component. And then finally, it's not entirely up to you how it rolls out. I have one very vivid, difficult memory of being on, when you do a rollout, oftentimes what will happen is at 6 the next morning, you do all 3 of the morning shows. You can only do 1 live, obviously, so they tape the other 2. You actually don't get a choice as to what piece of the tape they use. So there was one particular rollout where I said something and it was cut in a way that made me sound like I was valuing less the disabled community. And it was particularly hurtful to that community and particularly hurtful to me. There was an apology that was given to me from this major network online, and I spent about 2 months working with the disabled community because they were furious with me. So you don't get a say in all of it either. You don't get a say as you give a 6-minute interview, they get 90 seconds and they can pick whatever 90 seconds they want.
Absolutely, yeah, wow. Very impactful. It's very impressive to me that you're able to reflect the way that you are. It's so helpful, I think, for students here and also those in the audience to understand the thought process, the learning. So really appreciate the candor there. And I think we hear a lot in public health, both students and professionals, about communications, the value it plays, the changes that have happened, particularly in that component of public health. I would maybe argue that it single-handedly is changing public health, right? We have to pivot so quickly with the way in which information is coming out. And I think it's very helpful to hear from somebody who's not only been at the forefront, but also sort of has come up and learned and been able to recognize, okay, at that time, at that point, we did what we could. That's a really important, I think, way for students to also learn, to develop as a leader, to understand that, there's no perfect, but you do what you can, and you bring that forward. And I think that's what this conversation is all about too, so thank you. Bringing us to current, right, or maybe to close to current, right? Unfortunately, or fortunately, some things have improved a lot, and other things we're still trying to figure out how to fill that gap. We're seeing outbreaks of vaccine-preventable diseases, right? I think that's probably not a shock to folks here, like measles and pertussis. Somebody in your position has seen firsthand the ways in which our country can battle that. What do you think that these trends maybe signal about where we are in public health today?
If you had asked me what we needed to do to prevent the next pandemic when I left the office in 2023, I would say we do not know what the next pandemic will be. I think everybody anticipated that this pandemic would be an influenza pandemic, not a SARS-CoV-2 pandemic. And just because we got SARS doesn't mean we're not getting influenza. So I think we don't really know what the next pandemic will be. I gotta say, Mpox was not on my bingo card for 2022. So we just don't know what those threats are gonna be. And so what we really need is an infrastructure that is capable of tackling any threat that comes. In my mind, that means a robust laboratory infrastructure, a robust workforce, and a robust data infrastructure. And we in this country have underinvested in all three of those. You are going to be fixing that. I'm really hopeful. The data infrastructure alone, I mean, when I got to CDC, there were questions like, brace yourself, can we fax you our COVID data on our sickle cell fax machine? Right, so we were getting data by fax, we were getting it by email, we were getting it by cloud, we were getting it by Excel. That's not how Coca-Cola would do it. That is not a way to run a data infrastructure. And so we had made a lot of strides. We at CDC had gotten about $1 billion over the prior 3 to 4 years to bolster the data infrastructure in this country, for everybody to sort of just get a sense. If you're thinking $1 billion is a lot, I will tell you in 2016, when Mass General Brigham, where I worked, went to Epic, it cost the system $1.2 billion. One hospital system in one state. And the CDC got $1 billion for the country. We had counties that needed more than that. So that's the investment in our public health data infrastructure in addition. And we need that infrastructure. If Ebola landed if a patient with Ebola landed in Texas and then flew to Des Moines, Iowa, do we know where the closest lab is that could actually even do that test? And how long would it take for the sample to even get there? And oh, by the way, when it does, is there a laboratorian there who knows how to work the machine that does that test? That's what I'm talking about with regard to laboratory infrastructure and all the biohazard pathogens. So that's what I would have said in 2023. Today, I will say we are tackling yesterday's pandemics. We are now in a place where we can't tackle tomorrow's. We can't even think about tomorrow's because we have to tackle yesterday's. And I will also say the flip side of that, which is 92% of Americans, even today, even amidst the confusion, even amidst what's going on, 92% of Americans vaccinate their kids. They vaccinate, or are vaccinated themselves. And I would bet you if you polled 100 people about their favorite flavor of ice cream, about anything in this country right now, you couldn't get 92% agreement on much. So there is still a lot of agreement on, there's been an intent to sow confusion. It's working, but what we can say is that there's actually a lot of consensus about vaccines, and we have to continue to be loud about it.
Absolutely, thank you. I did want to say $1 billion sounds like a lot to me, but I know it's not, right? And we're talking about big dollar amounts here, right?
Yes, and I think there have been estimates that it would be about $15 billion to really do the public health infrastructure, data infrastructure. That sounds like a lot until you start hearing about defense budgets. Just saying. I mean, COVID killed more people than casualties of all of our wars combined.
Wow, yes. Thank you. And I think that's actually a really important point. I asked it because I think when we talk about comms, right, and how public health issues are framed, I think what I hear is, oh, well, that's a lot of money. Why do we need more, right? Or why can't we do more with what you have? And so I asked because it is important to have the framing, right, for folks to appreciate the comparison between public health gets pennies to the right to the dollar a lot, and you know better than anyone, right? So I really appreciated that.
If I could tell a story.
Please.
So one of the things, what people do sometimes ask me, like, what's one of the proudest things that you did at CDC? And we put 700 million doses of vaccines into arms. I'm really proud of that. That's like never been done before. Thank you. That's not what I was going to say, though. The proudest things are the things that you all have no idea about. And that's actually the problem with public health, right? Like, and people have said that over and over again. So Operations Allies Welcome, you will recall, was bringing 72,000 people from Afghanistan into the United States. Most of those people should have had a medical clearance before they left Afghanistan, but of course the challenge around how that happened, it did not happen in country. So it had to happen on US soil. That generally doesn't happen. That is the work of CDC and your public health service members to do that work. And so we brought 70, now I'm agnostic, I'm apolitical, I'm really trying to just deliver health. But we have a responsibility now to do these medical clearances for 72,000 people, so we deploy people to do those clearances. If you go back to look at what was happening in Afghanistan at the time, there was a measles outbreak. 25,000 cases of measles in Afghanistan that year. And Afghanistan and the Pakistan border is one of the few places that has endemic wild-type polio still. So when they were bringing all these folks in, we would get calls like, we're worried about COVID, and I would say, I think we have other things to worry about too. So it took within 4 days of the first plane coming into the United States into these mass convention centers with the screening that was happening for us to have our first case of measles. It took another week, and we had 4 more cases in another site. And so I made a very unpopular call at the time. They were not, the administration was not happy with me, and I said, all of these people need to be quarantined. Do you remember those? You remember that video? Yeah, wasn't happy. And we need to vaccinate them all. And so we led a huge effort. We got 96% of vaccines into folks, and then we quarantined them for 21 days. I was not a popular soul at that moment. We had a total of 44 cases of measles that were imported during Operations Allies Welcome, and not one got in the community. So that is a major, I mean, and you all never heard about it, right? So like a massive, massive public health effort to prevent. We all also knew that there were probably there was probably under vaccination in the Afghanistan diaspora where people might go, and that measles outbreaks might occur if we had folks enter there. So again, this is like what we do in public health. We stay up all night and do the hard work so that something doesn't happen.
Wow, yeah, it's incredible to hear, right, what folks have seen before from your, perspective, and also just to kind of hear how it unfolded. Appreciate that story. I also would like to highlight just you really spoke to the construct of public health. If there's no problem, it means public health is working, right? If people don't see it, it means that public health is working. And I think in that construct is the difficulty in communicating the value. And so it makes our jobs really difficult, and it also requires folks who are up to that challenge, which you clearly were and are, and we all appreciate it. And I just wanted to highlight that because that's a lot of why students, I think, pursue the field of
and people don't know what public health does. So like when people say to me, like, how are you, Rochelle, gonna regain the trust in public health? And my next answer I generally say is, who brushed their teeth this morning? And everybody raises their hand, I brushed my teeth. I was like, well, you used the tap water, right? So public health is doing something, because you used the tap water this morning and it's probably clean and you probably feel safe using the tap water brushing your teeth, right? So there is a remarkable amount of trust in public health. You just don't know it in your everyday life.
Absolutely. And we were thinking similarly. I had a question about what would you talk with folks about accomplishments that folks may not know or have not seen. So I'd love to give you the floor also. We would love to also hear about things that we wouldn't know otherwise.
Yeah, maybe I'll tell two stories. One is for the infectious disease geeks in the room. So in about 6 months into my tenure, we had a case of a child, I believe in Texas, that had passed away from Pseudomonas pseudomallii. This is a gram-negative rod. We have a little bit in the soil in the Mississippi Basin, but it's not endemic here. And most of these cases present a little bit like tuberculosis years after you've been exposed generally in Asia. So this 2-year-old had never traveled and had died of Pseudomonas pseudomallii. And so that was curious, and people were kind of scratching their heads. And a couple months later, somebody else in Wisconsin was infected with Pseudomonas pseudomallii, chronically debilitated from it, but did not pass away. So we ended up with these 4 cases, 2 of whom had died, 2 of whom and they were in 4 different states, and they had never met each other, and they had never traveled. So out goes my disease investigators, my EIS officers, and they go to each of these homes and they do like good shoe leather epidemiology, right? And they are like doing this full investigation and scratching their heads. They sequence all 4 of the bugs and it's the same bug. So like, and the bubble over my head, I'm like relatively new there, is they are not going to find this, right? How are they possibly going to find this? So they submit this story actually to a major medical journal, and they say, like, when they find the source, you can have the paper. And they found the source. Does anybody want to know what it is? It was a plug-in air freshener that was made in India. All 4 of the households had it. And they cultured the air freshener, and it's lavender chamomile from Walmart, and they cultured and each one of the air fresheners had Burkholderia Pseudomonas pseudomallii. And so this is it's like kind of a crazy story, right? And this is what they do. It's been taken off the market. So like that's what public health is doing for you. I will tell one other story, and that is Robbie Goldstein, who is a dear colleague of mine. He was a trainee of mine in infectious disease. He's now the Commissioner of Health in Massachusetts. He and I were on service several times together. I was a young attending, he was a trainee, and we just clicked as we took care of patients. He could finish my sentences, I could finish his. And we had a pretty rough case, and we cared for this gentleman for a long time, and this gentleman passed away after we'd cared for him for a long time. And I said, Robbie, let's go give blood, because that's kind of what I do when I have a bad day, is just like put good back in the world. And Robbie said to me, I can't, I'm gay. This was in 2016, and I had known Robbie was gay. I just had forgotten insensitively that we were still in a time when gay men couldn't give blood. And this was also around the time of the Pulse nightclub shooting, where gay men signed up in droves to give blood and they were all turned away. And so Robbie and I wrote about this with our colleague Hannah Sachs. We advocated for changing the rules to give blood. And then I get a phone call to go to the CDC, and now I'm at the CDC, and I call Robbie and I say, you want to come join me as my senior policy advisor? He joins me, and then we looked at each other and we're like, we could actually do something about this from here. And we had like willing and wanting colleagues. Rachel Levine, who is the Assistant Secretary of Health, was really interested in sort of moving this policy along as well. And so we were able to do it just before I left. The policy changed, and in August of 2023, Robbie and I donated blood together.
Wow. Thank you for those 2 stories. I also have worked for Dr. Levine, so these stories are near and dear. Well, they're true, right? But they're near and dear to my heart. I think they both really illuminate different components of why public health is so important. I would say on the first one, if we need a catch line, like that's why public health is vital, right? It's those small things. Without the EIS, you know, we wouldn't be able to
Protect the health.
yes,
Health, safety, and security of America. Yep.
Absolutely. And I think your second story really highlighted the humanity, right, in why it's important for public health. We look at all people, right? It is important to, it's a profession which looks to close gaps and boost people up who are at a disadvantage, right, who don't have the benefits to access, right, all of these different components of health, and health is a right, right? It should be a right. And so I think your story illuminated, I mean, it's for folks, I think, who are not as familiar with that, please go and look it up, because that story, the very folks who were shut down, right, are from the same community that were blocked from helping, right? And the data didn't indicate that there was a reason, right, why those rules should still be there.
It
So
was
I
far
love that
outdated.
example.
We wrote about it. It was far outdated. The data did not support it. But it took us, I mean, it took 6 years after that event to change. And Robbie pushing pretty hard. Well, I was at CDC. We were able to make it happen.
Yeah. I love that. Thank you. So I think folks would be curious to hear a little bit about what you're working on now, especially like the Vaccine Integrity Project, if you're willing to talk
Yeah, of
about
course.
it.
Yeah.
If you'd like to.
There, you know, in the change of administration and having been in the front lines of COVID with the prior administration, a bunch of us became concerned, especially with sort of new health leadership, that vaccines may be in trouble. And so I had been invited by Mike Osterholm to give a guest lecture, and Mike is an epidemiologist, former state epidemiologist in Minnesota. He and I got to be friends, and we had a conversation where he said, well, what's going to happen if things really kind of go sideways on vaccines, and how would we know it, and what should we do? So he and I joined forces and started doing some listening sessions from academia, from medical societies, from insurers, from state and local health departments, to say, well, what would we need to do if we didn't have a functional ACIP? And what would the triggers be to know that we needed to get started? Like, how would we know? Things were not looking great. There were some comments that were made, a few outbreaks here and there. And then while we were having those conversations, ACIP was fired, and we said that's probably a trigger. And so we started a tiny group that has grown a bit out of the University of Minnesota called the Vaccine Integrity Project. And it has evolved. We are not an advisory committee on immunization practices. There's many things that the ACIP does that we cannot do. But one of the things that ACIP used to do really well is formed the evidence base for how vaccine recommendations were made. And that evidence base didn't exist anymore and was not presented in a way that was, I will say, unbiased review of the evidence. So this was now April or May, and we looked in the mirror on the calendar and we said, oh my God, we have respiratory virus season coming up. So last summer, we said we better review the full body of evidence for RSV, COVID, and influenza to allow the societies to have that full review of evidence so that they can make recommendations for the fall. There were 17,000 papers that needed to be reviewed, and so we put a team. We put a team together of like 8 or 9 to review the data, and then we added like 5, and then we added 5 more, and it became a team of about 25 people to review the evidence. It was 500 papers that we put forward to review the evidence. All of those papers are in a full lit search. You can click on every abstract on the Vaccine Integrity Project website, and then we did meta-analyses, and we sort of delivered that, went through peer review, and got published in the New England Journal to just sort of demonstrate this is, you know, this is gold standard transparent science. This is how it should be done. So then we took on the hepatitis B birth dose, vaccine birth dose, and we did a full scientific evidence review for that. We are in the process of doing one for HPV as well as for Tdap in pregnancy, and getting started again for the respiratory virus season for 26-27. All because we think the societies probably don't have the resources to do this kind of work, and they do have a responsibility now to provide recommendations at a time where I think there's now conflicting recommendations from our current administration.
Absolutely. Thank you for sharing that. I think we have time for a quick final question. So looking ahead, what do you see as the next major public health challenge that we may face?
You know, I think it's right now it's our lack of trust in the brand of CDC has been, I'll say, hijacked. I think that the people who are using that brand are not necessarily the people talking for the subject matter experts of the agency. Those people are, many of those people, it's been cut by about 25%, but many of those people are still there doing incredible work. You're just not hearing their voices. And so when you say we don't trust the CDC anymore, who are you really talking about? Are you talking about the people who are using the brand, or are you talking about the people, the subject matter experts who are still there doing incredible work and trying very hard to dampen down outbreaks that you might not even know about, a viral hemorrhagic fever outbreak in the Congo, where they are actually still sending subject matter experts and laboratorians to sort of deploy and do that work, or a diphtheria outbreak somewhere else in the world. So that, I think, is really a problem. It was a problem when I got to CDC to sort of reclaim the brand, because there had been things posted to the website that had not been vetted by subject matter experts. And I do worry that if one of these next huge public health threats happens relatively soon, that there has been an intent to sow that doubt, and there hasn't been a real plan, vision to rebuild as of yet. The agency itself, I'm deeply worried about. There has been a massive, there was a DOGE activity, and then there has been a massive exodus of some deep subject matter experts. I'll tell you, when MPOX, that I mentioned before, not on my bucket list or my bingo card for 2022, when that happened, I called a tiny little branch of a division at CDC that had been funded $1 million a year. That was our monkeypox branch. And they had a tiny little $1 million budget, and they had been to Nigeria. They had done the work. These people had developed the lab tests. They knew how well these vaccines were going to work in the specific place, because they are probably one of the few places in the world that does work on mpox. And so I had that expertise kind of at my fingertips in an extraordinary fashion. When most of America had never heard of the disease, I had the people who had been working on it for decades. And that, I think, has been undervalued. And when you have that kind of mass exodus, what worries me is the core capabilities that we as a country need, that we don't necessarily need everything tomorrow, but you may need to call on these and hope that you have these subject matter experts that have since left.
Absolutely. Thank you. What a wonderful way to conclude, right? It's really important to make sure that we're keeping that front of mind. So we're going to transition now into the Q&A component. So just a moment, I'll let folks know how it's going to work. So we have mic runners who will come to you. Please put your hand up if you have a question, and we will go from there. Yes. So if you're a mic runner, if you could just bring the mic over to somebody, then put your hand up so I know, and we'll call on that individual for a question. Okay, yes, please.
Hi, my name is Michelle Wagner, and actually, Rochelle, we crossed paths at IDSA for a short time. But anyway, it really resonates with me about the whole communication issue, and how prevention is so, it's just not as sexy as a cure. And I am an alum of GW, and then I had the pleasure of working with so many physicians. And I just wonder how you balance your hat of prevention as being so important. And I think of physicians as the cure after the fact. And what it brings to mind in particular is the obesity epidemic and the Ozempic drugs and how they're saving lives from strokes and people are losing weight. And I heard several public health professionals say, but we need to prevent this in the first place. And so I just kind of thought about your two hats in public health and a physician and balancing that.
And there's actually a long story of this in HIV, treatment as prevention. You both have to be true. So first I will say, when I'm wearing my stethoscope, it is about the patient in front of me. When I'm doing work in public health, it is at the population. It is at the prevention level. You can't necessarily take a national guideline and sort of say, but this person is allergic to the first 3 drugs on that guideline. You can't give them those drugs on the guideline. So you do, like, it is a little bit, you have to wear both hats. I will say though, like as we're doing the work of prevention, there are still plenty of people with disease that we have to manage, right? And one of the beauties in the work of HIV is it turns out that treatment is prevention. And there are many kind of similar stories where you can say, if I actually treat this disease, I lower the viral burden that is out there for everyone, and that prevents disease in general. That's probably true for COVID, it's probably true for hepatitis C, so there are you can talk about many situations where they're very synergistic in mission.
And I'd like to encourage students too, if you're in the audience, let's make sure that we have some student voices as well. Okay.
Thank you for being here. I am an MPH student, which is my second career, and my name is Jan Paul. I have a question from a global health perspective. I know you worked at the CDC, you were at the helm of the CDC, but we also have seen, say, the WHO and the whole of United Nations infrastructure also reduced in personnel, in staffing, as well as the budgets. So what do you see as the solution to not only convince the US, but the whole world that the WHO is important?
Yeah, I mean, I think that some of that is trickle effects from lack of investment here in the United States. CDC actually has offices in 60 different countries, so we have a very large global footprint. And we always used to say a threat anywhere is a threat everywhere. And so I do think that, like, given the frailty of the infrastructure domestically and globally, we are starting to see cracks in our ability to manage some of these outbreaks. That's happening here, and I think it will happen. I think it will happen internationally. I certainly don't wish it on any of us, but I think it will happen internationally. Among the things that I think is really a challenge is that health is one of these beautiful places where we have some diplomacy, we have some soft power, and we have some diplomacy, and we've lost a lot of that through, the loss of USAID, through our pulling out of the WHO. I think all of these things, among the things where we share so much data is in influenza. And CDC is one of those places that we get sequences from around the world so that we know what is circulating, and to sort of think through what should be, twice a year, what should be the vaccine that we are deploying, the components of the vaccines given those sequences. This is a data point from several months ago, but as of the withdrawal of the WHO, those sequences have diminished by about 2/3 that we're getting in. So if we can't even see what is happening around the world, we can't protect ourselves. And then we, of course, have this challenge of, like, but there's an Ebola outbreak in DRC, and we are among the teams that goes there to really help, or, name the Nipah outbreak in Bangladesh. So, I mean, we work, there's so much diplomacy there that sadly I think is going to be lost. I know CDC is still deploying to certain places quietly, but yes, yes.
Hi, my name is Sia, and I'm a first-year MPH student. Thank you so much for your talk so far. It has been so informative, and it's already opened my mind up to so many thoughts and like everything. What's a trade-off you've had in public health that students might not expect, and how did you approach it?
I'm sorry, what?
What's a trade-off you've had in public health that students might not expect? For example, during COVID, I'm sure there was new data coming out about the vaccine every day. What was your priority at the time? So like saving lives, or like how did you pick what was the right choice and how did you do it? Does that make sense?
Some of these are not decisions. Some of them were made at the executive level, to be clear. I didn't make all of those decisions. The purpose was to blanket the most good as much as you can. And some of the trade-offs that I made, or some of the ways that I upset people, were actually, and this is really where I started, they weren't necessarily intentional trade-offs. They were more, I didn't see that one coming. So I'll give you an example. In in June of 2021, there was a dog that came in with 34 other dogs imported from Azerbaijan. Have you heard this story? And this dog ended up, well, so this dog came in with 34 other dogs, and he came in through this dog. It turns out dog importation is mine. Who knew? Yeah. So this dog came in, went to O'Hare, then to Philly, then to a pet store, then was bought, and then seized and went to a vet. And this dog had rabies. Yeah, and that becomes my problem. So we then tracked down the 45 people who had been exposed to this dog and the other 33 dogs, and there was one cat that it was with. And we then needed to quarantine, vaccinate, and give post-exposure prophylaxis to. And so it turns out that there's an industry of bringing in dogs, selling them. That's an industry, and now there was an industry of falsifying the paperwork for vaccines. So we clamped down on that. That was an appropriate thing to do, of course, right? We don't have dog rabies in this country. We have no interest in reintroducing dog rabies into this country. So we clamped down on that. And within weeks, I received some pretty angry hate mail. Does anyone want to guess from where? I'm sorry? No. Department of Defense. And let me tell you, you don't want them mad at you. I think I got like 1,000 emails of pictures of dogs. And the military couldn't bring their pets home. Exactly. Oh, so it was, again, it was one of these, I didn't even appreciate, like, what can I think, what can't I see, who's going to be upset by this policy? Now, of course, these were like military who had just served our country, who maybe had these animals, and these were the most supportive things during this incredibly difficult time, and I just made it difficult. Like, I totally appreciate where they were coming from and why they were angry and why I had all these letters from the Senate. But like, those are the things where you're like, I wish I could see behind the corners and to be able to do those. So much of this was not like the trade-offs. There were certainly trade-offs about how are we going to, when you only have 1 million doses of Jynneos vaccine and you have 100 million requests for them, how are we going to make sure that we're doing that in some sort of way that is in an equitable fashion with regard to the states who are got it, those kinds of things. Those were some difficult conversations, and you bring in experts. But a lot of the most difficult times were, God, I wish I had seen that coming.
think we have time probably for one more question, and then we'll wrap up.
Hi, I'm Maria. I'm 1 month away from graduation, which is scary. With that in mind, I kind of wondered whether you still encourage people that are trying to enter the grad market or job market to pursue a career in government. I know we were talking about the CDC and the Institute, and I heard the chuckle from everyone just now. It's kind of rough entering the job market as a new grad, especially as there's loss of trust in the institutions, but also loss of stability, I feel like. As a person who's going into public health and is the daughter of a pediatrician, I was kind of told that, you'll be guaranteed because the government's always hiring public health people. But I was just wondering, do you still encourage people to pursue it even though the brand of the CDC has been hijacked?
Yes. How's that for definitive? Congratulations and yes. But let me expand on that a little bit. It's hard to find a job in the government right now, and the people who are there are having a hard time. And I do believe this is going to be really short-lived. I will tell you the first thing that I did when I left the CDC is I got a fellowship at Harvard Law School. I went to talk to the lawyers. Now, why'd I go talk to the lawyers? I don't know the first thing about the law. In fact, there are some people here who will very much know I don't know the first thing about the law because they worked with me there. I would find myself, I was like, I got epidemiology, I got costs, I got infectious disease, and then I'd be on a Zoom screen with 11 lawyers. I was like, we're not speaking the same language here. So what I really wanted to do was just like diversify and sort of meet people whose field I didn't fully understand. So if you have to marinate for a little while you're waiting to go find that perfect job in public health because it's not available tomorrow, find yourself marinating in spaces that are uncomfortable for you so that you can learn more about those spaces where you will have to interact one day and where that diversity of opinion, thought, bias, risk will be new for you and you will bring something to them. I taught at the law school. I have no business teaching at the law school, but like I had people say that this was one of the most interesting classes because they were teaching me law and I was teaching them how their risk assessment of this made my work impossible. And we could meet in these really interesting places. And so I would say, we need public health innovators for the future. We definitely need that. This rebuild is going to happen and you all are going to be part of that solution. And in the meantime, there's like a lot you can learn and gain from other sectors as you think about what you want to do next in the public health space.
Thank you so much. That concludes this part. I wanted to say thank you so much, Dr. Walensky. It's been an honor. I know that folks have enjoyed it as much as I have. And now I'll turn it back over to Dean Gibbs to close us out, please.
It has been an honor to have you here at the school. I am so touched by the presence of you and your incredible messages. And I want to echo what Rochelle said, that I think that there's a tremendous future for public health. And one of the things I'm most excited about with being here at GW is we're conveners and we bring together people that talk about things that are really hard to talk about. And we've had RFK on campus, and we had Jay Bhattacharya here, and we've had Rochelle, and we get difference of opinions. And I think one of the things that's really important is for us to listen and to think, what is the other side saying? Because everybody has a perspective and nobody is wrong. It's just being able to listen and to be able to interact and finding where those areas of synergy are. So thank you for bringing that to our attention. I have great faith in the field of public health because of leaders like you and because of our future generations like you. And so there's lots to look forward to. Thank you for your hard work in this. On behalf of the school, we have a small gift for you. Hopefully you'll use this tote, which you can see has our cherry blossoms. I'm sorry you've missed them outside, but we'll see them upstairs, yes. And thank you very much for coming. I hope everybody can join us in the convening center across the way for some pizza and cake. Looking forward to celebrating a lot of wonderful things. Thank you for joining us.